Well, welcome to this pharmacology drug class review on the anticoagulants, heparins, specifically including unfractionated heparin and low molecular weight heparin. In this session, I'm going to explain why parenterally administered anticoagulants matter and make heparin and low molecular weight heparin easy to understand, clinically relevant, and if applicable, even prepare you for your exams. Now, heparin represents a critical treatment option in the management of DVT, PE, and ACS, acute coronary syndrome, especially in the acute treatment of STEMI. So you're going to encounter these repeatedly on exams and also real-world patient care. Hey guys, I'm Dr. Busti, and thanks for joining me on This Is Why, a show dedicated to helping healthcare professionals understand the why behind pharmacology and the drugs that we use every day. When you understand the why, the how becomes easier, because that's when mechanisms of action start to really predict that therapeutic effect that we desire. Understand the side effects that can occur, contraindications, monitoring parameters, and also counseling points. This means instead of relying on just memorization, you can reason your way through the process and which parenteral option to use and make safer, more confident decisions at the bedside. Now, like all of my drug class reviews, we're going to cover that core content, okay? Because you got to learn that core content just like I did. I mean, this class of drugs has been around almost my entire career. Okay? 30 years in nursing, pharmacy, and medicine. I've administered it, I've dispensed it, I've prepared it, and I've ordered it, right? So it's just that common and high yield. But we need to cover what drugs make up the class. We're going to cover the main indications and uses, some of which I already alluded to, but there's some additional nuances. The net benefit of the class. Why reach into the bucket of heparins compared to other anticoagulants? And we'll dive again into that pharmacology, okay? So that's all that core content. And then we're going to take it to the next level of clinical knowledge and application. Because you shouldn't just learn the facts and memorize facts. You should understand where these drugs are used and some of the nuances associated with them, okay? So with that, let's cover the agents. Now, what I try to do is break it down into the agents that we use in the acute care predominantly environment versus chronic care environment. And then I even list over here on the right side of the screen here options that are available outside the United States, like Tinzaparin, right? We don't have that here in the United States. Now, Dalteparin, Enoxaparin, Fondaparinux, and unfractionated heparin are more common in the acute environment. And when I say heparin, I'm referring to unfractionated heparin typically in the context of being administered by IV infusion. Yes, we can administer unfractionated heparin in subcutaneous injections and theoretically use them in the chronic care scenarios for prevention or prophylaxis. However, with the evolution of the low molecular weight heparins and ultra low molecular weight heparins, or what is known as the factor 10A inhibitor Fondaparinux, those days where we used to do that are less and less, but not zero, of course. So that just helps us to see that the heparin drip is obvious for the inpatient side, right, versus outpatient management. We can use these drugs in both environments. Okay, let's now move to the indications and also the uses that we see in everyday clinical practice. Not every nuance, but the most common indications. Now, in the acute care, we're referring to things like ST segment elevation, MI, and specifically as it relates to acute coronary syndromes, especially those who are going to PCI, percutaneous intervention. Now, it doesn't mean that we don't use them in STEMI. Okay? There's a lot of debate about this, depending on which of the areas of literature that you read. There's been some controversial topics that have been published on this, in my personal opinion. But if you look at the totality of the evidence, especially with Enoxaparin, the use of these drugs in acute coronary syndrome do have a role, especially in the acute unstable situation, basically an unstable angina or an active MI. Okay, what about venous thromboembolic events, DVT, PE? Yes, for the acute, for sure, right? Chronic care, we can continue that on and treat patients, and we can also offer prophylaxis because patients can be taught how to administer these medications. And so those are the most common indications and uses. Let's now move to the net benefit. Again, this is where we try to give our perspective on the drug class as a whole. Why would we think in this direction when we have other drug classes that we could access? So heparin and low-molecular-weight heparin and Fondaparinux, again, generically make up this heparins. That's not really fully fair, and I would be cautious about saying they're all the same. They are not. They're the same, right? There are enough differences between them, but when we learn about them, especially like in a drug class review like this, it's good to learn them in side by side where they're similar, but where they're different, okay? So each of them offers us some unique dosage formulation and options for administration and utilization specific indications. For example, the heparin drip. If we need very tight, specific control of a certain degree of anticoagulation in an acute setting, that can give us that. We can titrate based on the PTT for that patient care scenario and turn it off if we need to. Okay. Thankfully, the drug doesn't have a very long half-life, so it goes away pretty quickly. The low molecular weight heparins offer subcutaneous administration, and with that subcutaneous administration, it's convenient for inpatient, even for our nursing staff. Less pumps, IV tubing, we don't need all that. And it's predictable. Okay? The problem with unfractionated heparin is it's not predictable, right? So we see these net benefits showing up that in parentally administered options for these acute and chronic scenarios where we need to protect the patient from a propagating clot, okay? That is their primary benefit, but it comes obviously with some baggage. Okay, so let's now pivot and start getting into the pharmacology. Now I want to take a moment here and just give you a little footnote. Stay with me, okay? Some of you are going to be like, Dr. Busti, I don't care. Don't do that, okay? I understand. And sometimes we look at things and we like start to feel a little lost at the moment. Just follow me. Trust me, okay? I've been doing this, again, for 30 years, nursing and pharmacy and medicine, and I can tell you that I wish, in hindsight, I would have learned this stuff very early on in my career. It would have saved me from some of the confusion that I had and misunderstanding about the use of the drugs, okay? So with that, let's jump into just some basic physical characteristics between the subclasses, if you will, of the heparins and the anticoagulants. Okay. This particular image is available for you at thisiswhy.health. All of our images are available for free at download. The link is provided in the description there of the video and the description on YouTube. So feel free to go there and you can access that information. Share it, use it for teaching if you need to, okay? That's why I put it together. But this particular image has, I know it's sort of a cartoon style of images, but it's trying to raise an important point about the heparins, and that is their sizes matter, right? You heard the word low molecular weight heparin. You heard me say, and especially other lectures, ultra low molecular weight heparin. Some people use that terminology. That ultra low molecular weight heparin is really referring to our factor 10A or direct 10A inhibitor, Fondaparinux. Why? Because it's the smallest. And you can see that I list here under unfractionated heparin the molecular weight, under the low molecular weights, and then obviously under Fondaparinux or the factor 10A inhibitors. And you can see that the size is getting smaller. That's obvious by the visual. It's also objective, okay? And the reason that matters is because one of the biggest problems with unfractionated heparin over here on the far left column is that you see molecules that have varying ranges of sizes. You have small molecular weight molecules and you have very large molecular weight molecules. You have things in the middle in the size of molecules, all over the place. Whereas the variability in the size of the molecules of low molecular weight heparins are, guess what? More consistently all low molecular weights. They look more alike. Yes, they vary by a little bit in their sizes, but it's taking the unfractionated heparin bottle of medicine and literally filtering off the large molecules and throwing them away. So you're left with these low molecular weight molecules that look relatively the same, okay? And then when you go over to Fondaparinux in the far right, you see even smaller. Now, what are these triangles that you see here? That's the pentasaccharide sequence. That pentasaccharide sequence that's consistent with all of them, right? Unfractionated heparin, low molecular weight heparin, Fondaparinux all have the pentasaccharide sequence because that is the essential component to binding to antithrombin. You need antithrombin, which is endogenously made in the body, in order for these drugs to work. And so when they bind to antithrombin, by binding, this section binds to the antithrombin, it changes the shape of that antithrombin. We'll see that here in a minute. But before we jump into that, the size issue is relevant. When you have a lot of variability in size, like in the unfractionated heparin column, that variability causes an inconsistent or unpredictable pharmacologic response in each patient, one from another, because the size of the molecule can bind to other things in the body. And that's going to vary for one patient over another. And so we have standard doses that we initiate in patients, but the therapeutic effect that is seen with that dose in one patient over another is not the same. So what that means, guys, is that the interpatient variability in this group of unfractionated heparin molecules is high. That means it's not predictable. We have to start the infusion, and we have to constantly get labs, and we have to constantly titrate to find the therapeutic levels that are in our desired goals of the aPTT, okay? Whereas the low molecular weight heparins that have very little variability offer consistency. That means the interpatient variability is now improved. It's less. So that when I administer a certain amount of drug anti-10A units per kilogram of one low molecular weight heparin, and I give that to another patient, the desired or pharmacologic effect that's achieved is about the same. It's predictable. There's less variability. That reduces the need for monitoring because we know the effect that we're getting. That's good. That surpasses a weakness in unfractionated heparin, which is why we have to give the unfractionated heparin as a drip, and we can administer the low molecular weight heparin molecules in subcutaneous format that allow them not only a pharmacokinetic distribution over 12, sometimes up to 24 hours, depending on how it's dosed, right? It's predictable, low interpatient variability, but the size still plays a relevance into binding certain things. This binding of other things, of these molecules, comes up in HIT, heparin-induced thrombocytopenia, where these molecules can bind to platelet factor 4 and create an antigenic response in the body that creates basically a pro-thrombotic scenario. And the platelets are getting consumed. And in that consumption, you form clots and you infarct organs, and they develop multi-organ infarction. So we have to give them anticoagulants. We have to stop the heparins. and use direct thrombin inhibitors or possibly even Fondaparinux. Now, when you look at Fondaparinux over on the far right, it is the smallest. They're all the same. And because of that, it influenced also the mechanism. You're going to see here that unfractionated heparin in a minute and low-molecular-weight heparins can inhibit factor 2, also known as thrombin, but Fondaparinux cannot. And that's when it became its own drug class, direct 10A inhibitor, because it cannot, in its small size, bind in the two different binding sites of thrombin in order to exert a pharmacologic effect. So the size of the molecules influences what the drugs bind to in the body, that impacts the variability in the pharmacologic response. It also influences the interpatient variability, okay? And it also increases and influences the risk of hit. So the larger the molecule, the greater the risk of hit. The larger the molecule and variability, the less predictable it is from one patient to another. And that is why the low molecular weight heparin class, and even ultra low molecular weight heparin, which is really Fondaparinux, factor 10 inhibitor, have evolved and became strong competitors to the unfractionated heparin market, because it's just troublesome to have to do all that work to put someone on a drip, especially this day and age, okay? Now, I've summarized those things here also in this table, which again is available at thisiswhy.health for you for free. But I broke down each of those classes. You can see the unfractionated heparin here, low molecular weight heparin section here, and our direct 10A inhibitor specifically, or factor 10A inhibitor, Fondaparinux. I provide you the molecular weight in column 3, and then you see a couple things. You see the anti-10A units per kilo column. They're not interchangeable by dosing, especially the low molecular weight heparins. They do have variability, okay? And again, that goes back to the varying molecular weights, which are not the same if you sit there and you look at them, okay? I'm sorry, not that column here. Like, you see the molecular weights are very different. Even though Dalteparin and Enoxaparin are not that far away in their sizes on average, there's still variability. So they're still not the same dose. That means that the common dose of 1 milligram per kilogram subcutaneously administered Enoxaparin is not the same dose as Dalteparin. That means you cannot give Dalteparin at 1 milligram per kilogram. It doesn't work that way. They're dosed actually on anti-10A units per kilo, but that's too confusing for most clinicians. And I'm sure some of you are like, can you please stop talking about this? But the reality is I wanted you to understand why there is variability in the actual doses. If you read the actual product insert, you read the actual medical information about these drugs and the way they were dosed, you'll see milligrams per kilogram, but you also see anti-10A units per kilogram. And I wanted you to know why that's there. We avoid the use of the anti-10A units per kilo because it's just too confusing for most people, okay? But this last column is a very important column, especially as we move into the next couple images that I'm going to talk about. You can see that the degree of 10A, factor 10A, to 2 inhibition is not 1-to-1 in all of these drugs. It is for heparin, because heparin has small molecules, medium-sized molecules, big molecules, so they bind all of it, because they bind all kinds of stuff, which is, remember, not helpful in all cases, especially if you want predictability, variability. Whereas if you look at the low molecular weight heparins, you see that there's more factor 10A inhibition than there is factor 2. So it's more 10A inhibition. And then, of course, when you get to the factor 10A inhibitor, remember, its molecular weight's too small. It can't bind to thrombin at all. So it is a 1-to-0 ratio for that reason. Now, these agents, okay, we're gonna dive into that in a little bit more detail here in just a second. I'm going to show you another diagram that's going to help you visually put those things together. Okay? But remember, these agents are indirect anticoagulants. What I mean by that is they need something to be present. That antithrombin must be there for that pentasaccharide sequence to bind to, and I'm getting ready to show you that. Now, if you read some older literature, you might see that antithrombin is also known as antithrombin 3. It's an older name, but it's essentially the same thing, okay? So patients who have antithrombin deficiency, giving these agents is not going to exert a sufficient and adequate anticoagulant effect that you're hoping for in that clinical scenario, okay? So that is really important that you recognize that unusual nuance. Now, let's dive into taking that mechanism of the 10A and 2A inhibition and put that in the context of the coagulation cascade and the use of antithrombin. Okay, so this is where we're going to dive a little bit more. Just please follow me here, okay, because this is really important. So the coagulation cascade in its normal physiology is represented here. Okay, we have the intrinsic pathway that finally arrives at 10A. And then we have the extrinsic pathway, usually from some, again, injury to the vasculature, trauma, atherosclerotic plaque rupture, releases a bunch of tissue factor, right? But they both converge together on factor 10A. And then 10A is what converts prothrombin to thrombin, factor 2. So remember that 10A to 2 inhibition, those are the two clotting factors that we are interfering with. Now, if you don't fully understand the coagulation cascade, I do have a lecture that covers the basics and helps you to really understand what's happening in this cascade to solidify the formation of a clot, or also termed thrombus. But when the coagulation cascade is primarily activated in the formation of a thrombus, it's typically in a venous thrombosis. Things like DVT, PE, AFib, cardioembolic strokes. Whereas acute coronary syndrome, STEMI and STEMIs, are usually from atherosclerotic plaque rupture in an artery, which is primarily influenced and mitigated by, or created by, platelets activation. They're activated, they start to aggregate. But remember, they feed into the clot as well. So clots are made up of red blood cells, fibrin, and platelets. The concentration and distribution of those components varies depending on where the clot was formed and what system was activated. And so we give anticoagulants like heparins, low-molecular-weight heparins, Fondaparinux, to predominantly treat venous thromboembolic formed clots. Okay? So DVT, PE, and AFib with risk of cardioembolic stroke. So that's why we target that side. We're not giving antiplatelets for DVTs and PEs. We could. It's just not going to work as well as an anticoagulant. So when we think about the targets of therapy here, okay, you see that unfractionated heparin requires antithrombin in order to work. But the arrows here that you see here are the same thickness because the ratio of inhibition of 10A to 2A is 1 to 1. Okay, because remember, there's big sizes all over the place, lots of binding to things. Okay, now how do we know that? Well, this particular figure and diagram here shows this sort of effect mechanistically. Okay, again, it's meant to highlight what is actually happening at the cellular level from the pharmacodynamic effect. So here you have unfractionated heparin. Remember, again, wide variabilities. I'm only showing you one that's larger. Remember, it's got small molecular weight particles inside of it. It's unfractionated. It's mixed stuff. That pentasaccharide sequence fits inside of this space in antithrombin. Well, if you look at the binding site for 10A and thrombin, it changes from that square, again, from just for purposes of discussion, to a curved. And you see that factor 10A and 2 both have a yellow dot right here. That's one of the binding sites. 10A only requires one binding site. It doesn't matter the size of the molecule. Irrelevant. As long as antithrombin is present and had a conformational change, it is inhibited. But you need a molecular weight molecule large enough to reach around and bind to the second binding site on factor 2. So what that implies is if you have a small molecular weight particle that was here, you might not be able to inhibit all or some of that thrombin, which is what happens down here with the example of low molecular weight heparin. It doesn't have a big enough tail, if you will, size to wrap around and bind to this binding site. And as a result of that, it cannot inhibit factor 2 at the same ratio. And so for enoxaparin, the ratio is 3.9 to 1. That means it's inhibiting more factor 10A than factor 2. Whereas unfractionated heparin up here is 1 to 1 because of the variability in the sizes. Okay? So these are subtle mechanistic differences that influence the dosing and the way we administer the medication and why or why not we have to monitor the patient. It also correlates to the why patients develop HIT with larger molecules, which we'll see in a minute. So when you come back over here to the coagulation cascade, we had just looked at it with unfractionated heparin. Now we're looking at it with a low molecular weight heparin where the molecules are very similar in size but smaller, less variable. They have to bind antithrombin, but remember, look at the arrow here on inhibition of 10. It's thicker. Again, to try to create the imagery that there's more 10A inhibition than 2A inhibition. Again, that's consistent with the ratios. Okay. Now, when we compare Fondaparinux to that scenario, remember Fondaparinux is a ultra low molecular weight heparin. That's true. It has a pentasaccharide sequence, and that pentasaccharide sequence cannot be given by mouth. It will be degraded, right? So we have to bypass the GI tract, okay, which is why these are not DOACs, if you will, right? We can't administer these orally. We have to give them sub-Q or IV, okay? The low molecular weight heparins and ultra low molecular weight heparin Fondaparinux or direct inhibitor, those work best by subcutaneous administration. It leverages not only the mechanism, but it leverages a pharmacokinetic profile that is favorable for less frequent administration. Fondaparinux has less variability and a longer half-life. It can get away with less frequent administration compared to drugs like Dalteparin and Enoxaparin. But look at what is going on with the pentasaccharide sequence. Well, it binds to its binding site on antithrombin, so it requires it, just like the low molecular weight heparins, just like unfractionated heparin. And it causes the conformational change in the shape of antithrombin that allows it to inhibit factor 10. But remember, factor 2 to be inhibited has to be bound and inhibited by 2 locations. And given the size of this molecule, it's not able to do that. So that ratio is essentially 100% 10A and no 2. Okay? That allows for the least amount of binding to platelet factor 4 and the least risk of HIT, so much so that people use it to treat HIT, which we'll talk about in a little bit. Okay? It also reduces the interpatient variability by having all the molecules the same. Okay? And it improves the predictability or reduces the interpatient variability between us. So the dosing is predictable and reliable. Okay? Now, how does this all compare to the parenterally administered drugs, direct thrombin inhibitors? Well, direct thrombin inhibitors do what they say. They directly inhibit thrombin or factor 2. Okay? But they do it in a way that's different. right? They do not require antithrombin, right? Their size can wrap around even more so and grab it and hold on to it. So it is a direct thrombin inhibitor, just like Fondaparinux is a direct 10A inhibitor, okay? But it doesn't require antithrombin. And that is a unique difference between those classes of medications. But looking at Fondaparinux in the context of the coagulation cascade, that's why there's only one arrow going to factor 10 in its inhibition and interruption of the coagulation cascade. Woo! I mean, that's a lot, guys. I mean, I know. And most of you, even if you've learned the anticoagulants and heparins before, may not have heard some of that stuff. But guys, I'm telling you, having done this for so long and seeing the nuances and issues, these things, if you try to memorize them, it doesn't help. But what we're getting ready to dive into, which is the clinical knowledge and application, it starts to make sense of some things, okay? So when we start thinking about binding characteristics, interpatient variability, dosing reliability, predictability, who, when, what, that's why this stuff matters. So let's dive into the clinical application. All right, so the first thing is weight, okay, body weight. So you heard me talk about anti-10A units per kilo, which is too convoluted, difficult to anybody to really fully understand and remember. Number two is we converted that to milligrams per kilogram. So we converted the anti-10A units to milligrams because that's what we as clinicians understand, right? They're not interchangeable between the drugs, but that's why we did it, right? When you look at the clinical trials and the way these drugs were studied, they were studied in patients largely up to 150 kilos. And so unfortunately, when we have patients who are over that weight, our predictability, our reliability can be influenced where we need some additional considerations. Now, there are recommendations out there that have evolved over the years on ways to dose this. There are facilities or hospitals that have the ability to monitor things, and they're familiar with how to do that, and you can do it safely. Just realize it's not as straightforward and perfect like we want it to be. All right, so for enoxaparin, the standard dose is 1 milligram per kilogram, sub-Q administered every 12 hours in a patient up to 150 kilos. Now, this assumption is that they have normal, otherwise renal function, right? This is also for enoxaparin. It's not for Dalteparin. But that subcutaneous administration every 12 hours is nice. We don't need an infusion pump. I don't need an IV. The nursing staff doesn't have to draw labs and check PTTs and run up costs and all this crap that sometimes makes life very difficult, okay? So, but if you do have that patient who's over 150 kilograms, not only do you have a dosing formulation problem, but you're gonna need to probably consider dose adjustments and or titration to a target anti-10A levels, assuming you have access to do them. Not all hospitals or labs do. There are protocols out there that can help people if you have that kind of patient population scenario. Now, low molecular weight heparins in particular, yes, you can use heparin drips to create bridge therapy. Now, we know that to be true with our factor Xa inhibitors. The DOACs, specifically edoxaban, requires bridge therapy for that. Warfarin requires bridge therapy because warfarin's effect and therapeutic benefit can take up to 5 or more days to get where it needs to be. Okay. Now, apixaban, rivaroxaban don't require that bridge therapy, which is why they are more common and popular amongst clinicians. There is a dosing recommendation that you can use 1.5 milligram per kilogram of enoxaparin, not Dalteparin, but enoxaparin can be an acceptable alternative if you want to administer it once a day. In most common situations, that's in the inpatient environment, where the nursing staff and the providers are monitoring that and making sure the patient gets it. Because obviously if you miss a dose, then you're running the risk of not having the proper anticoagulation for that scenario. How do we monitor these drugs? Well, mainly in the context of unfractionated heparin, that's where we're monitoring things. Low molecular weight heparin, yes, we can do anti-10A levels, assuming your facility has that capability. Okay, but the reality is most people sometimes don't have access to that. So there's the PTT, okay, and then there's also the ACT. Now the PTT is more reflexive of the intrinsic pathway of the coagulation cascade. It's reflective of that part on the left side of the coagulation, whereas the extrinsic pathway from traumatic injury of the vasculature and things like that are the PT-INR. So when we look at drugs like warfarin, we're using the PT-INR because it's mainly impacting the extrinsic side of the pathway of coagulation cascade, whereas heparin is predominantly affecting the intrinsic side, okay? And so that's just an important differentiator. And our target, our goal, when we have someone on a heparin drip, not low molecular weight heparin, not Fondaparinux, but on a heparin drip, is to get the PTT to be about 1.5 to 2 times the upper limit of that patient's normal. That means you have to have a patient's baseline coagulation parameters and then go 1.5 to 2 times above that, okay? And that could take a couple hours. So we have bolusing regimens that we do, things to try to get the patient up and going based on their weight. But at the end of the day, you're going to have to monitor the labs and make adjustments, or the nursing staff will have to titrate up or down on the infusion in order to get what they're looking for, okay? That roughly, if you do 1.5 to 2 times the upper limit of normal, you should be in the 50 to 70 second window, okay? Now, there are some protocols that go up to 80. That's okay. The point of the matter is it's estimated you're in this window where you're trying to protect the patient from an acute thrombotic event versus it having too much and then now they're bleeding and we got to reverse it. Now, thankfully, heparin has a short half-life when being administered IV infusion. So if you are following anti-10A levels, your goals are typically in this range. Again, assuming that you have access to that, okay? Now, in patients, I want to make a side comment here. In patients who are going to, again, this is acute care, PCI, you know, they're going into the bypass surgery, they're going to need larger doses of heparin, and that's where the ACT typically is utilized more commonly. And so it is available as a bedside test. It can be done quickly to assess and apply those in those unique clinical scenarios, okay? Now, I want to talk about heparin-induced thrombocytopenia, and I first want to talk about terminology. And so I've put together this table, again, that's available for you at thisiswhy.health. And that link is available in the description of the video section there for you if you need it. But there's type 1 and type 2 HIT. Okay? This has evolved, and I've seen the terminology shift around a little bit, so don't get too bent out of shape about it. But the idea is that there's heparin-induced or heparin-associated thrombocytopenia, and then there's heparin-induced thrombocytopenia or type 2. Type 1 is the incidence is a little bit more, but it's not as bad. Okay? Yes, heparin exposure is there, but it's not as much of a concern as type 2. Type 2 is a problem because they form antibodies. And those antibodies are generated because the heparin molecules, especially those large ones, are binding to things and creating antigenic responses by the immune system in the patient. So, you know, when we get exposed to foreign substances, our immune system goes, I don't know what that is. Why is that here? Let's get rid of that. Right? It's doing its job. But sometimes it does its job and it creates a bad outcome in the response. So what ends up happening in these patients is while the incidence of this is overall lower compared to type 1, it's worse. Okay? These patients see significant drops in their platelet counts where they will typically see their platelets drop below 100,000. They'll have easily 50% reduction in their baseline platelet count because the platelets are being consumed. So here's the biggest mistake in patients or people trying to learn HIT. They think the antibodies are attacking the platelet and destroying it. No. It's turning on coagulation and platelets and forming clots. It's like disseminated intravascular coagulation. You're consuming endogenous components and you're forming these clots, okay? And so the problem with that is when these clots form, they're forming all over the place. And your platelets are dropping. And eventually you will then be at risk of bleeding because you've consumed all your platelets. And until your body makes more from megakaryocytes and you get the chemicals from the liver and stuff to create that differentiation, you're stuck. Well, how do you treat it? Well, you got to give them anticoagulants to stop this. So this is a huge drop in platelets that are being consumed, and patients typically are having clinical manifestations of it. Now, how does that happen? Why? I've been beating on this for a while. The size of the heparin molecule, the duration of exposure, the dose, all influence that risk. But really that size is important because you see here in this complicated chemical reaction, it eventually results in thrombosis over here. We'll get to it in a minute. Heparin binds to platelet factor 4. Well, where does that come from? From the platelet. Platelet factor 4 comes from the release of granules of the platelet. That forms a complex, okay? Because remember, it's binding to things. Heparin molecules, big ones. Well, the immune system, plasma cells or B lymphocytes go, I'm going to make antibodies against that, okay, that thing, and it forms this antibody. So IgG antibodies that form, and that complex with the heparin molecule, because the antibody goes and it binds on it, it activates and stimulates tissue factor production, but it also activates platelets that release macroparticles that turn on even the coagulation cascade around it, the environment. So thrombin's coming from the coagulation cascade, but you've got platelets and thrombin. And all of that together, combined, leads to thrombosis. So those platelets are dropping because they're making clots over and over and over again. And then those clots eventually will clog up the vasculature to something that it's going to, right? And that's why it can be multi-organ. And so this is an acute, life-threatening situation that you need to stop the drug, and then you're going to have to anticoagulate them. Now, the risk factors associated with this, again, are based on source of heparin, the size of the heparin, and the duration, especially 4 days or more, okay? Those are important. Repeat exposures. So in the last 30 days, you've had it, certainly higher risk. So the earlier on, the more stimulated the immune system is to respond. So the dose, treatment doses versus prophylactic doses. Gender seems to be at higher risk, probably because of the estrogen that tips the scale in the amount of clotting factors that are being made, okay? Now, you can detect these antibodies, right? And there are ways to kind of help you predict the likelihood. There's something called the 4T score, 4T, right? And so those help you to identify patients who have possible HIT. Now, you should be monitoring serial or interval CBCs so that you can get the platelet counts, right? Or just order the platelets, depending on how your labs work and prefer, but you want to monitor that trend, and that trend is what's helping you. So that's important because when we start to treat them, we're stopping the unfractionated heparin or the low-molecular-weight heparin immediately, and then we have to start them on a treatment. right? And we're going to continue that treatment until the platelets recover and get above 100,000 and stay above it, okay? Because antibodies don't go away very fast. Now, donaporoid is historically listed as a treatment option. It's just not available in the United States. Fondaparinux, a factor Xa inhibitor, an ultra low molecular weight heparin. Sounds counterintuitive. But remember, it's such a small molecular weight that the risk of hit is very, very low. And there are clinicians and hospitals that have protocols that allow you to use it. So if you see that being used, that's why, okay? It's the unfractionated heparin and other low molecular weight heparins that are gone. Now, direct thrombin inhibitors, those are the drugs of choice. In the acute phase, we're going to use some of the parenteral agents in particular, okay? Argatroban probably being the most common outside of bivalirudin, okay? Those are the two most common direct thrombin inhibitors that are used. The other ones, neither off the markets or not available in quantities sufficient and stuff like that, okay? Now, when we think of reversals, let's say the patient, obviously we're giving anticoagulant, the patient can have bleeding. And they can bleed on any one of these agents. Now, if I'm giving it to you by IV infusion, well, like I said, one of the advantages of giving heparin by IV infusion is I can just turn it off. The half-life is very short. It will rapidly go away within a couple hours, and it's just the decreased risk of bleeding, all right? Now, I can give a drug to reverse these agents. Now, think about if I subcutaneously administered it, okay? If I subcutaneously administered it, well, like Lovenox or Enoxaparin or Dalteparin, well, I've got, that drug is leaking in the subcutaneous fat over a course of 12 or 24 hours, depending on how I've dosed it. So as I give the antidote, right, in those situations, I'm only binding what is present. And the antidote is protamine sulfate, okay? Protamine sulfate. So we stop infusions if it's on heparin, and we will administer protamine sulfate, especially in the acute, and for every 1 milligram of protamine sulfate, you will neutralize about 100 units of heparin. So you have to figure out how many units. So if you're giving 1,000 units of heparin per hour, so you think of the last hour, how many units did I give? If I gave 1,000, right, so then I have to give 10 milligrams of the protamine in order for that to neutralize what is present likely in the blood at minimum, okay? Now, we usually do it at a dose up to typically no more than 50 milligrams. Going higher than that has been associated, doesn't mean everybody will, and there are people that do it, but it has been associated with causing hypotension, bradycardia, and even anaphylactoid-like symptoms, okay? But that's important to consider if you're going to be giving it. Now, if you've administered, you can do adjusted doses based on how fast you've been giving the infusion of heparin and how much time has elapsed from when you identified the actual bleeding that was occurring, okay? Now, going back to the sub-Q, what do you do in that situation? So the IV makes sense, but what do I do in the sub-Q? Well, it's not straightforward, and you won't be able to fully, put all those together, but you figure out how many units you gave, even if you have to convert it back. This is where pharmacy can be very helpful as a consult to how much, convert the milligrams that we gave into anti-10A units, trying to get an idea of what you have administered. And that can be an exception that allows you, but you stagger the protamine administration because you give whatever you give in the IV, you're only neutralizing what is available, okay? You still have more that's going to be leaking in, so we stagger it, right? We give 50% of the dose up front, and then we give 25% of the protamine in a few more hours, and we give another 25% a few hours later, and hopefully you are, over that course, blocking more, especially if they're bleeding, okay? Now, we do not give, we don't want to try to do this IM and stuff like that, and patients, you know, we don't even give the heparin molecules, low molecular heparin molecules IM. The risk of that administration technique is high risk for obvious bleeding, right? Because the muscle is highly vascularized, okay? Okay, so next we are talking about monitoring. I mentioned that monitoring parameters are PTT, especially for the drips, ACT if you're using very big doses and you need bedside sort of assessment for cardiothoracic interventions. We're going to get those platelets from our CBC at baseline so that we can compare, especially if the patients start to develop the patterns concerning for HIT. And then we're going to also monitor in the CBC, not just the platelets, but hemoglobin and hematocrit, looking for trends. Especially if our patients are starting to feel short of breath, feel weak, lightheaded, dizzy, pale, blood pressure's dropping, like they're bleeding from somewhere, guys. So that's why you want a baseline, and then you want to be able to compare the interval change in the hemoglobin to look for or start investigating where they may be bleeding. And sometimes you won't be able to see it right away. Sometimes you have to turn the patient over. Sometimes it's in their stool. Sometimes it's in their urine, right? Renal function. Now, low molecular weight heparins and low molecular weight heparins and Fondaparinux are highly renally eliminated. So their dosing is influenced by renal function. Well, heparin is too, but if we're administering by heparin drip, we're just adjusting based on that patient's renal function. Okay, but we need renal function at a baseline for dosing of low molecular weight heparins and Fondaparinux. Okay, BUN to creatinine ratios are something that are also considered, and we want to always consider a high ratio. A high ratio, especially 30-to-1, would be suggestive that the patient might be bleeding in their stomach. And as they break down the blood, the hemoglobin breaks down, and the urea nitrogen cycling, which is basically helping to break down that ammonia from the amino acids that make up the hemoglobin, start to rise really high. And so what happens is that we have this unbalanced amount of BUN to creatinine, which is suggesting that there's some source of protein metabolism going on somewhere. Now, it doesn't guarantee that the patient's having a GI bleed, but it certainly is a parameter that can be indicative of that. So be very careful of that. And then, of course, looking for blood in the stool, hematuria and melena in the stool. So hematuria is blood in the urine. Melena is dark black stool, right, from high up. If there's bright red blood, it can come from polyps, fistulas, diverticuli, cancer, hemorrhoids. Any of those things can bleed, okay? And then, of course, you can monitor 10A levels in certain patients if your facility and labs offer that flexibility for you. What about our special patient populations? Now, pregnancy is unique because historically we should avoid warfarin. It crosses through the placenta. There's risk of the baby also getting some bleeding risk, and we don't like typically drugs passing through placentas, right, and increasing the risk of bleeding. So historically, warfarin has been one of those contraindicated. That doesn't mean no one ever does it. There are OBs that do use it, and there is some emerging data that offers some guidance on that, but I would say largely you should use it with caution, and you should do it with somebody who's more of a specialized and expert in managing those situations. But what's the deal with pregnancy? Well, remember, pregnancy increases the risk of thromboembolic disease because the high concentrations of estrogen stimulate the expression of clotting factors, tipping the scale that favor coagulation. We see the same thing with birth control pills. And so patients who have underlying hypercoagulable disorders, when they get pregnant or they start birth control pills, they can form DVTs, PEs, and many times they'll infarct the placenta and they keep aborting or miscarrying, and so they can't hold on to the pregnancy. In those cases, that's sometimes how patients find out they have a hypercoagulable disorder. And so those patients need to be put on anticoagulants to protect them from clotting so they can hold on to the baby, and they also don't get DVTs, PEs during the pregnancy. Those things can kill the patient, the mom, which can then obviously then kill the baby. And so we do need to be very careful. And so this is where typically what is preferred historically is low molecular weight heparin. And the DOACs also have some emerging data, but again, overall insufficient. So you should, at this point in time, as this evolves and we get more comfortable and things get evaluated, you should consult, obviously, with the OB provider who specializes, or a hematologist who specializes this and is comfortable with managing, and talk to the patient about the pros and the cons of various treatment options. Okay, what about another population, frostbite, right? Been out in the cold temperature too long, and it doesn't take much to lose fingers and digits, right? So cold temperatures, unfortunately, cause the loss of those digits because they form clots. The cold temperature encourages coagulation, therefore it increases the risk of clots. So you actually may even consider thrombolytic therapies in these patients who are experiencing frostbite in order to try to salvage and open up that tissue and see if it is still alive enough where you get some reperfusion of the tissue. But boy, that's a difficult one. Okay, guys, so let's now wrap this stuff up. One of the things that we are providing you is a table. This table is available at thisiswhy.health, again for free. It summarizes the various anticoagulants and the subclasses. So we have warfarin on here. We have unfractionated heparin, low molecular weight heparins. The factor Xa inhibitors are the most common DOACs. And then, of course, our direct thrombin inhibitor, including the DOAC dabigatran. It's summarized. It covers the key characteristics: onset of actions, risk of drug interaction, main mechanisms, molecular weights, dosings, considerations in food, renal. It's a way to have a snapshot of all the drugs and their classes, and not perfect, complete, obviously, but it's a snapshot. Okay, quick reminder. If tools like this help you, please feel free to use it. Share it with your friends and your colleagues. It was designed and it helped me, right? And so I use it with the teaching that I do at the bedside with students and residents and things like that. So feel free to use it. All right, so heparin molecules. We have unfractionated heparin. We have Dalteparin, Enoxaparin, Fondaparinux, right? These represent the heparins, but even though they're not all the same, please don't consider them that way. They just share a lot of mechanistic characteristics, but remember, they are different in their inhibition of their factors. Indications, we have the acute myocardial infarction, and STEMI, right? Higher doses, the cardiothoracic surgery, and of course, DVT, PE, treatments, and prophylaxis. Mechanisms, right? Don't forget, these drugs require Anti-Thrombin. They all have that pentasaccharide sequence. Their size of the molecule influences their binding to other things, the predictability of the dosing, the interpatient variability, the risk of hit. It even influences the half-life and the dosing. All those things are influenced because of the size of the molecule. And that's why we broke them down. That's why I teach it the way I teach it. Side effects are obviously bleeding. If you're on any one of the heparins or low molecular weight heparins, risk of hit, especially with those larger molecules, a longer duration, less with Fondaparinux. Right? All these things are important. Now, our low molecular weight heparins and Fondaparinux can be given subcutaneously. You can administer them IV. In fact, Enoxaparin is given as a bolus IV. You just get all the drug in the body right then and there. And so the therapeutic effect starts right away, okay? Monitoring, aPTT for heparin drips. There's really no monitoring for low-molecular-weight heparin or Fondaparinux. All right, guys, that was a lot. I hope you found it to be helpful. Please subscribe to the channel on YouTube if you haven't done so already, and give us a like. We really would appreciate that. It helps us to continue to provide content like this for you and try to help others. And thanks so much, guys, for what you're doing. Thanks for investing in your knowledge, your understanding of these things, and never stop learning the why, because remember, it makes sense of why we do what we do, and it makes the how much easier. Take care.